Okay, hello to everyone. Welcome to the Global Frailty Network inaugural webinar of the Frailty Seminar Series 2024 and 2025. My name is Jorge G. Ruiz. I'm a Medical Director of Geriatric Medicine and Memorial Healthcare System in Hollywood, Florida, and faculty at Florida Atlantic University in Boca Raton, Florida. And as you probably already know, our speaker for our inaugural webinar is Dr. Dae Kim, and I will introduce him in a second. Just few housekeeping issues. Remember to use the WebEx chat button when asking questions, and it's at the bottom of your screen. We are recording this session, so we'll make it available in our YouTube channel. And by the way, you can see many of the previous presentations there. And then we'll continue, of course, next month on October 8th, I think it's 8th, and I'll tell you in a second. October 9th, sorry, our next webinar will be by Dr. Alan Sinclair, and I'll give you the details at the end of the talk. So Dr. Kim will present, and then we'll have time for questions. And now let me introduce him. Of course, we're honored to have him today. Dr. Kim is Associate Professor of Medicine at Harvard Medical School. He's an Associate Scientist at the Hinda and Arthur Marcus Institute for Aging Research at the Hebrew Senior Life, a highly prestigious geriatric institution in the United States. He's a geriatrician in the Division of Gerontology at the Beth Israel Deaconess Medical Center, another prestigious institution in Boston. He is, again, a geriatrician, researcher, and mentor at the Hebrew Senior Life Marcus Institute for Aging Research, where he directs the Frailty Research Program and co-leads the Center for Analytic Sciences in Aging. He's supported by research grants from the National Institute on Aging. Dr. Kim's research focuses on the measurement of frailty using large healthcare databases, the outcomes of drug therapy and surgical procedures, and the integration of frailty assessment into routine clinical practice. He has developed a claims-based frailty index for U.S. Medicare data and recently launched a website called eFrailty to disseminate frailty assessment tools to clinicians and researchers, and he'll be talking about that during this webinar. At Beth Israel Deaconess Medical Center, he specializes in preoperative frailty assessment for medically complex older adults undergoing transcatheter aortic valve replacement. As a mentor, Dr. Kim advises trainees and early career investigators in frailty research, geriatric pharmacoepidemiology, and health services research. His contributions to the field have been recognized with the 2023 American Geriatric Society Thomas and Catherine Yoshikawa Outstanding Scientific Achievement for Clinical Investigation Award, and his election to the American Society for Clinical Investigation in 2024. And I just wanted to add that Dr. Kim has just published an excellent review on frailty in older adults in the New England Journal of Medicine, and I encourage you to review that narrative review that was published just a few weeks ago. So he'll be talking about eFrailty, making frailty assessment accessible to clinicians and researchers. So Dr. Kim, the floor is yours.
Thank you so much for the introduction and for the invitation to speak to the global audience of clinicians and researchers who care about frailty. This webinar is going to be a little bit different from the previous webinars in the past years because I am not going to talk much about my own research or original data. Instead, I'm here to introduce a newly developed website tool called eFrailty that can help you deliver better care to your patients and improve frailty measurements in your own research. So the work that I'm presenting today has been in part funded by the grants from National Institute of Aging, as well as our own internal institutional fund. I have 3 learning objectives today. I'm going to introduce eFrailty and its electronic calculators to assess frailty in clinical practice. I'm going to talk about how to apply the evidence and best practices of geriatric care based on the frailty assessment information. And then I will briefly discuss future directions to incorporate frailty into routine clinical care of older adults. As a geriatrician and researcher who study frailty, which frailty assessment tool should I use? This is the most frequently asked questions from clinician and researcher colleagues who are aware of the concept of frailty, but they're not quite familiar with dozens of definitions and tools available for frailty assessment. Once I answer this question, there are more questions to follow. Where can I find the assessment tool? How do I score it? What is the cutoff point for frailty? And how does one frailty tool compare to other frailty tools? So as geriatrician, researcher, and also educator who measure and study and teach frailty, the investigators, my colleagues, and myself felt the need to fill this gap by creating a one-stop shop for commonly used frailty assessment tools. After 2 years of hard work, our group has launched an educational website called eFrailty.org early this year. And our main goal was to make frailty assessment accessible to clinicians and researchers within and outside the geriatrics and aging research. I'm going to briefly tell you about this eFrailty. So you click Overview of Frailty Tools to see which frailty assessment tools are available on eFrailty site. The website hosts 15 validated frailty assessment tools and their web-based calculators. There are 10 tools for general populations and 5 tools for specific patient populations, such as surgery, cancer, liver disease, and myeloma and aortic valve replacement. And it also includes most commonly used frailty tools like freed physical frailty phenotype and deficit accumulation frailty based on the items from Comprehensive Geriatric Assessment, or CGA-FI. Before you decide which tool to use, you can compare the administration time, assessment domains of each frailty tool, and specific target population for which each frailty tool was originally developed by reviewing this table. If you already know which tool you are going to use, you can go straight to Tools Library to choose the tool directly. So here's a screenshot of the list of tools are available on the website. If you're unsure, you can click Help Me Choose a Frailty Tool button here and follow the algorithm and find the tools that is recommended for your clinical context. So I'm going to illustrate how to use eFrailty tools based on patient cases. I'm going to start with patient Mr. C, who is a 93-year-old man and who are recently hospitalized for hematochezia. And he was diagnosed with a sigmoid adenocarcinoma. And laparoscopic sigmoidectomy is being considered. So on further assessment, his other comorbidities include COPD, CAD, hypertension, hearing loss, type 2 diabetes, and history of TIA. He takes 7 prescription drugs. He reports no fatigue, no weight loss, and his last serum albumin was within normal limits. And he continues to exercise on treadmill 20 minutes and some resistance exercise 20 minutes in the gym 5 times a week. He's independent in all basic ADLs and need help with certain IADLs, such as transportation and meal preparation. And he does report difficulty pushing a large object like living room sofa and performing heavy housework such as raking leaves and shoveling snow. On physical examination, he has a BMI of 27, a mini-cog score of 3 out of 5 points, repeated chair stand time of 13 seconds, and usual gait speed of 0.83 meter per second, and his grip strength is 28 kilogram in the dominant hand. So I go to eFrailty and select help me choose a frailty tool. And then the next question comes up is, why are you measuring frailty? And I choose risk assessment before stressful treatment. And then the following question is, what is the treatment? And I click general major surgery. Then you get risk analysis index, which has been validated for general surgical population. And you enter the information and you get the score of 20 for Mr. C and what it means for post-operative mortality. So in this case, a 30-day mortality of 0.5% and then 1-year mortality of 7.3%. And then there are key references supporting these data, as well as alternative tools to risk analysis index. And it lists a clinical frailty scale, frailty phenotype, and then comprehensive geriatric assessment-based frailty index, or ScDAssociate. So I'm curious how frail Mr. C is if I use different frailty tools. I'm particularly interested in clinical frailty scale, free frailty phenotype, and the ScDAssociate. These three tools are listed on this screen. Especially the ScDAssociate is a 50-item deficit accumulation frailty index using routinely collected items from a comprehensive geriatric assessment. So if I administer CFS, Mr. C's CFS is stage 5 mild frailty, which is characterized by more evident slowing and needing help with higher order instrumental activities daily living, like transportation and heavy housework. And then when you administer free frailty phenotype, his score is 1. It's called pre-frailty, and he has the 1 point from the muscle weakness. And then according to the ScDAssociate, Mr. C's frailty index is 0.267, that is consistent with the mild frailty. And then the report of the ScDAssociate also include these two graphs. The radar plot on the left, the blue area here indicates the degree of impairment in each assessment domain, like medical domain, mobility, muscle strength, ADL, IADL, cognition, and nutrition. So Mr. C has moderate risk impairment in muscle strength domain, as well as medical domain, and mild risk in mobility and IADL, cognition, and nutrition domains. So this radar plot can be really helpful to identify targets for interventions to optimize health status before his upcoming surgery. Sometimes we call this a prehabilitation. And the plot on the right shows the mean values of frailty index and the 99th percentile values of the frailty index for men in blue and women in pink in the US older adult population. So Mr. C's frailty index is right here. which is slightly lower than the mean frailty index of the men in the same age group. So to summarize Mr. C's frailty assessment results, the CFS showed mild frailty, frailty phenotype showed pre-frailty, and ScDAssociate showing mild frailty. So the question is, why does frailty phenotype give different results from CFS and ScDAssociate assessment? So this type of question I get a lot, and this really motivated our group to think about how these different frailty scores are correspond to each other. And we all know that the different frailty scores that uses different components may give different results. But we went on to assess that relationship by creating a frailty score crosswalk. So I'm going to turn to frailty score crosswalk on eFrailty website and compare the scores from different frailty tools. So in this figure, the y-axis shows the ScDAssociate score that ranges from 0 to 1, and the x-axis shows 8 commonly used different frailty tools and their correspondence with the ScDAssociate score. So for Mr. C, his ScDAssociate score is 0.26. So it's right here. And that is consistent with a frailty phenotype score of 1, because from here to here, these ranges of ScDAssociate score is consistent with 1 point in frailty phenotype. And also the CFS, Clinical Frailty Scale Stage 5, is consistent with a frailty index score about 0.2 all the way to about 0.39. So this is actually not an inconsistent result. These are different tools that give different labels to the same patients with a similar degree of frailty. The next patient is Mr. L, who is an 85-year-old man who was hospitalized for syncope and congestive heart failure exacerbation. He was diagnosed with severe aortic stenosis, and he's being considered for transcatheter aortic valve replacement, or TAVR. So his medical history includes anemia, arthritis, atrial fibrillation, CAD, CKD, dementia, diabetes, hypertension, heart failure, and hearing loss. He takes 12 prescription medications, and he reports fatigue, but no weight loss, and his serum albumin was normal, and he does not engage in any physical activity or exercise. He needs help with many ADLs except for feeding and walking inside his house. He needs help with all IADLs, and he reports difficulty pushing a large object, stooping, crouching, or kneeling, lifting 10 pounds, climbing stairs, walking half a mile, and heavy housework. On exam, his BMI is 32. His MOCA score is 12 out of 30. He's unable to perform chair stand. And his walking speed is 0.5 meter per second, and his grip strength was 22 kilogram. So according to the CFS, he is CFS stage 7 that is completely dependent for personal care. And according to the free physical frailty phenotype, his score is 4 for points for exhaustion, low physical activity, slow gait, and weak muscle strength. For ScDAssociate, his frailty index is 0.7, which is consistent with advanced frailty, and he has a high degree of risk or impairment in almost all domains except for nutrition that was showing moderate risk in that particular domain. And compared to the rest of the population, his frailty index is right here and very close to the 99th percentile value of men in the same age group. So based on this assessment, you can see that this person is really frail, and even with a minor stress procedure like TAVR, can be really high risk procedure for this particular patient. And his risk of dying and then functional decline or lack of improvement will be quite high after this procedure. So looking at Mr. L's results, the CFS showing severe frailty stage 7, frailty phenotype 4 points, that's consistent with the frailty, and the CGFI showing advanced frailty. So frailty phenotype, because there are only 3 levels of robust, pre-frail, or frail, classified Mr. L as frail, whereas CFS and the CGFI, that gives more refined degree of frailty, classifies him as having severe or advanced frailty. So how does his frailty score line up on the crosswalk? So 0.7 on the frailty index is similar to, consistent with 4 points on the frailty phenotype, and then stage 7 in the clinical frailty scale. So far, I have shown you some useful features of eFrailty website, such as overview of frailty tools, tools library, and help me choose a frailty tool algorithm, and frailty crosswalk. So now I'm going to talk about what eFrailty users do after frailty assessment. We believe the eFrailty website has made frailty assessment more accessible to clinicians. So what would be the next step? In my opinion, there are 3 main areas that users can use frailty assessment for. First, users can predict adverse health outcomes and prognosis. Numerous studies have proved that both brief frailty assessment tool and more comprehensive frailty assessment tools can achieve this risk prediction and the prognostication. So I will not really talk about this in today's lecture. The second, users can provide interventions for frailty and individualized care based on the frailty assessment. But for this purpose, I would say that you will need a more comprehensive frailty assessment tool than a simple screening tool to design an individualized intervention. So what are the interventions for older adults with frailty that have been proven effective in randomized controlled trials? So before I present evidence for specific interventions, there are a few caveats to keep in mind when you look at this evidence. The first is the overall quality of evidence is low because of the heterogeneity in study population, frailty tools used to identify frailty in the study population, and the outcomes assessed in the randomized controlled trials. So some studies included people at risk for frailty, such as people at pre-frailty stage, versus other studies included people with existing frailty or both. Some studies were conducted in the community setting. Other studies conducted in hospital and nursing home setting where the prevalence of frailty is over 50% of patients in that particular setting. There are numerous frailty assessment tools, and some studies use frailty phenotype. Other studies use deficit accumulation frailty index and many other tools. And the results on the frailty is not always consistent. So an intervention may improve a frailty score on one type of frailty measure, but may not show the similar improvement in other frailty measure. And the outcomes that were studied in these randomized controlled trials really vary. Some studies actually look at the change in frailty or development in frailty according to a specific definition, but other studies use some of the other relevant measures of function like mobility, muscle strength, or ADL disability, or some clinical outcomes like falls and mortality, as well as healthcare utilization. So this table summarizes the efficacy of various frailty interventions from randomized controlled trials. I divided the target population into these 4 segments: community dwelling older adults at risk, so they're not frail yet, and community dwelling older adults with frailty, hospitalized older patients, and nursing home residents. And the green plus sign indicates there is at least one RCT that showed a beneficial effect on at least one of these outcomes, like frailty change, mobility, strength, ADL, disability, falls, death, and healthcare utilization. The red minus sign indicates RCTs showed no or little beneficial effect on any of these outcomes. And then open circle indicates the evidence is inconclusive. And then the empty space means there has not been an RCT in that particular setting. So as you can see, exercise has a beneficial effect in all 4 settings, protein intake in 3 settings, and then a nutritional supplement like vitamin D and omega-3 was not shown to be effective in the community dwelling older adults who are not frail yet. And the evidence remains unclear in people with frailty or nursing home residents. The comprehensive geriatric assessment was beneficial in people at risk for frailty or with frailty and hospitalized older patients. Medication optimization seemed to be beneficial across all 4 subpopulation, and sex hormones like testosterone or growth hormone supplement have been studied but did not show definite evidence on any of these outcomes. So generally speaking, interventions efficacious in improving frailty, like such as exercise and comprehensive geriatric assessment, impact a range of physiologic systems, whereas interventions that narrowly target a single physiologic abnormality have not shown the efficacy in improving frailty or the outcomes of frailty. So I'm going to go into a little more detail about what has been studied in each of these interventions. So first, exercise. The most evidence exists for resistance training, but the optimal exercise program remains unknown. In community dwelling older adults, aerobic exercise and resistance training, 30 to 60 minutes per session and 1 to 4 sessions per week has been shown some degree of effectiveness in randomized controlled trial. The hospitalized older patients, most of the studies, the intervention was delivered or supervised by a physical therapist, focusing on resistance training, with 20 to 90 minutes per session, 2 to 5 sessions per week. So these are such a wide range of heterogeneity in the way intervention was delivered. And there is some evidence that yoga can improve mobility, muscle strength, and balance. For protein intake, so older adults do not have robust protein, muscle protein synthesis after exercise or protein intake. This is called anabolic resistance. So the expert recommendation of 1.0 to 1.2 gram of protein per body weight kilogram per day is recommended for healthy older adults to prevent age-related sarcopenia and frailty. But the current recommended dietary allowance of 0.8 gram per day may be inadequate because of the anabolic resistance. And people who have acute or chronic illnesses or at risk for malnutrition, the requirement may be even higher, like 1.2 to 1.5 gram per kilogram per day. The exception is the people with a chronic kidney disease. So in that case, higher protein may accelerate the decline of kidney function. So 0.8 gram per kilogram per day is recommended for people with chronic kidney disease. So how can we achieve this high level of protein intake? There are some tips that we recommend to the patients. So ingest sufficient protein, like at least 20 gram or more at each meal over the course of the day. And also combining resistant exercise with the protein intake in close temporal proximity may promote a greater anabolic response. Comprehensive geriatric assessment consists of a systematic, multidimensional evaluation and also development of a coordinated care plan and follow-up. So although it says assessment, it doesn't end with just assessment. It has to have a care plan and then action step and then follow-up after the assessment. It is typically delivered by a geriatrician or experienced clinician or multidisciplinary team, and typically includes medical domain, functional status, physical function, psychological assessment, and social environmental domain. And the evidence is stronger for hospitalized older patients with acute medical condition or injury like hip fracture and surgical patients. The deficit patterns from the comprehensive geriatric assessment can inform targeted intervention. So we can think about, for those with a high level of risk in the medical domain, we can adjust disease management targets and stop treatments of unclear benefit or high risk of harms. And people with impairment in mobility and muscle strength domains, we can refer patients to physical therapy and exercise program and think about home hazard reduction. People with ADL or IDL disability, we can refer patients to occupational therapy, social work, and other supportive services. For those with high level of cognitive impairment, we can consider treatments for cognitive impairment and stop or taper psychotropic drugs that may increase the harms in these patients. In the nutritional domain, we can have dietitian referrals and the nutritional supplement focusing on protein intake. So medication optimization includes comprehensive medication review and de-prescribing of potentially inappropriate medications. We can use American Geriatric Society Beers criteria or the stop-start criteria to optimize medication management. The evidence seems to be stronger for the nursing home residents who are at higher risk for drug-related adverse outcomes. And the studies have shown reduction in falls, hospitalization, and mortality in nursing home residents through medication optimization. So when we evaluate older adults, we consider many interventions, care principles, and models of care. We need to think about any disease-specific guidelines, preventive care like vaccination and cancer screening, and the interventions for frailty, as we just reviewed: exercise, physical activity, nutrition, counseling, and supplementation, comprehensive geriatric assessment, medication review and optimization. And home-based primary care is an option, as well as providing social support. But due to heterogeneous health state of older adults, it is often challenging to identify most suitable interventions for each patient. So I believe that understanding an older adult's frailty level on a spectrum of fit to frail can streamline the care of older adults. So for fit and pre-frail individual, the goal is to increase physiologic reserve to maintain independence. For individuals with frailty, the goal is to preserve physiologic reserve and prevent avoidable stressors. And for those with end-stage frailty, the goal is to provide comfort. With these principles in mind, we can apply disease-based guidelines for fit and pre-frail individuals and individualize chronic disease management, considering trade-off between disease symptoms and treatment burden. And we can de-escalate care in patients with end-stage frailty. Vaccinations can benefit all individuals across the frailty spectrum. Cancer screening is appropriate for fit and pre-frail individual, whereas it should be individualized based on the time to benefit from the screening and the remaining life expectancy. The cancer screening should be stopped for those with end-stage frailty. As I just reviewed, the clinical trials have shown that exercise, nutrition intervention, comprehensive geriatric assessment, and medication review and optimization can help people who are at risk of frailty, like pre-frail, and those with frailty. And especially medication optimization can help with even people in the nursing home, and many of them have end-stage frailty. Home-based primary care can be offered to those with frailty or end-stage frailty, and social support is important across the frailty levels. The third application of frailty information is that users can use frailty information to guide decisions about stressful treatments. The benefit of assessing frailty has been shown in older adults undergoing antineoplastic chemotherapy for cancer and those undergoing major surgical procedures. So this is the graph that you saw earlier, showing the mean value of frailty index for men and women, and the 99th percentile of frailty index in the US older adult population. And there is a maximum deficit burden that threatens survival. As a frailty index is a proportion, the theoretical maximum number is 1.0, but a lot of times you don't really see many patients with a number close to 1.0. And multiple studies have shown that really 0.7 to 0.8 range is where the maximum threshold, that beyond that level, survival is very unlikely. So you keep this information in mind, and we can go back to the patient, Mr. L, whose frailty index was 0.7. So he's already very close to the 99 percentile, or top 1% in the population in terms of his frailty index level. So we can say that even with a minor, less stressful procedure like TAVR, he is really at high risk for developing functional decline and then prolonged nursing home stay or complication and death after the procedure, because he has really little reserve to tolerate additional deficits from hospitalization as well as the procedure itself. However, Mr. C, whose frailty index was a little below the mean frailty index of his age-matched group, so he has more reserve to tolerate additional deficits. So it's because of his level of frailty, he is at higher risk compared to the younger patients, but he's not at a prohibitive risk for undergoing surgery. So we can use this frailty index information to explain to the patient where their health status is in the population distribution and what is likely outcomes of the surgical procedure, and help them make a more informed decision. But the decision will be also considering personal goals from the patients, as well as the preference of the patients about invasive procedure, needing for nursing home stay after the procedure, as well as hospitalization. So now I'm going to just give you a little bit of update about eFrailty early experience and what potential next steps are. So we launched this eFrailty website early this year. And as of yesterday, the total number of active users have grown to almost 6,800 users. And this graph shows daily active user count over the course of this year. And we saw that the United States, China, Canada, Hong Kong, Brazil, Mexico, Australia had the highest number of active users over the course of this year. And this graph shows that the darker color indicates more active users in that country. So what are the frequently used frailty assessment tools based on the number of views on our eFrailty website? So CGA-FI had the largest number of views, followed by clinical frailty scale, frail questionnaire, and study of osteoporotic fracture scale, free frailty phenotype, risk analysis and index, and essential frailty toolset. The essential frailty toolset is the frailty assessment tool specifically developed for TAVR and aortic valve replacement population. So after we launched this website, we received a few comments through the website email. And one of the questions was, are there any frailty assessment tools that patients can self-administer? So among the 15 tools hosted on eFrailty, we have a tool called Prisma 7. That is the only tool that was developed as a self-administration. But there seems to be interest among patients who want to know about their frailty status and discuss it with their primary care physicians. And then we heard comments from researchers that there are frailty scores that can be calculated from existing database, such as electronic health records or administrative claims data or insurance claims data. And our team has discussed the possibility of creating a compendium of well-known database frailty scores for information purposes, although eFrailty website will not be able to calculate the score because of data privacy issue and the complexity of the calculation algorithm. There are bigger questions in the field that need to be answered to improve the care of older adults with frailty. In terms of the strategies for frailty screening, now that we have validated frailty assessment tools, and there are some interventions with a proven efficacy from RCTs, should we adopt a routine frailty screening and perform comprehensive geriatric assessment for screen positive patients and deliver tailored intervention in primary care setting? But currently, the most evidence supporting the routine frailty screening is in oncology and surgery, where patients are facing acute stressful treatments. The studies that evaluated routine frailty screening in the primary care setting have not, consistently shown the benefits of routine frailty screening. And there are several explanations that include differences in candidate selection, in how frail patients are identified in routine care versus some of this highly controlled RCT setting, and also selection of what is the control group, what is the standard care of the comparison group. That also determines the degree of benefit of the intervention. And also, the most challenging part is the fidelity and adherence to some of these interventions in routine care setting. As I mentioned, there are several database frailty scores, which can be useful as a screening test for frailty. But how to integrate these automatically calculated database frailty scores into clinical practice workflow remains to be determined. What I've seen is that frailty score from these databases can be a useful tool for population health because it can approximate patients' frailty level without doing an in-person assessment. So if the hospital or health system want to allocate resources or develop a special pathway for frail patients, this database frailty scores can be useful. But still, how to use this information in the individual patient care still needs to be determined. The goal of frailty screening is to identify older adults with frailty and refer them to appropriate, additional evaluation and resources. But then the availability and access to these resources should be considered when we talk about how to screen frailty and at what threshold we're going to actually refer patients to. It may depend on the healthcare system and the country where these are being employed. In terms of the intervention development for frailty, the interventions that target the biology of aging at the cellular or even subcellular level may hold the potential for preventing or reversing frailty. Some of those interventions that have been studied include caloric restriction, intermittent fasting, metformin, rapamycin, and senolytics. And this is an active area of geroscience research that we'll learn more about in the future. And what are the standard sets of outcome measures to evaluate frailty intervention? As I briefly mentioned when I reviewed the existing evidence from RCTs, different frailty tools may give different results on the change in frailty or development frailty when it was used as an outcome. So what are the standard sets of outcome measures to evaluate the effectiveness of intervention remains to be determined. And then the other important aspect, utility of frailty, is to help making decisions for other medical or surgical interventions by assessing their frailty. So do treatment benefit and harm differ by patients' frailty level? This is an important question, even though we may not directly address frailty itself, but it can still be helpful for deciding what drug therapy or surgical procedure we can recommend if we know patient's frailty level. This is an increasing interest to many researchers, including our team, whether the treatment effect differs by patient's frailty level in randomized controlled trials and real-world database research. So these are the couple of papers that our team have published. The one on the left is showing frailty as an effect modifier in the post-hoc analysis of randomized controlled trials. And then the one on the right is using real-world routine healthcare databases to assess the benefits and harms of drug therapy in older adults with different degree of frailty. So I'm going to conclude my talk with the following messages. Knowing where your patient is on the fit to frail spectrum is useful in applying evidence and geriatric care principles. And eFrailty can be a useful tool for you to deliver individualized care and improve your research measurement of frailty. And we need further research for optimal strategies for frailty screening and development of interventions to prevent and reverse frailty. But thank you for your attention.
Thank you, Dai, for an excellent presentation and a review of the evidence. And of course, I'm sure that many of our participants today and through the website will be able to access the eFrailty instruments and the website and apply it in their own clinical and practice and maybe research. So we have a few questions. We have some minutes there. And somebody's asking about whether there is a copy of the slides. Better than that, and I send you the link, you'll have access to the video of this presentation, so you probably will not need the slides. And you'll be hearing Dr. Kim again. So one of the questions is it better to have a specific frailty tool for each specific purpose? And I think you addressed a little bit of that, Dai. For instance, a frailty tool for assessing the risk of chemotherapy and a different tool for new dementia treatments. In addition, when should one choose multimorbidity burden measures over frailty tools? And I think that's a deeper question, Beth.
Yeah, that's an excellent question. So we have frailty tools that were developed for general population of older adults. As I mentioned in the beginning when I introduced eFrailty tools. And then there are specialized tools that use probably similar elements of frailty tools developed for general population, but the calculation of each points for each element may be optimized to predict the poor outcomes in that specific population. So, so I think it is helpful to actually consider both. And but my approach is that use a general, frailty tools for general population as a first step, and then you can supplement that information by using a specific patient population specific frailty tools to improve the accuracy of the prediction for a treatment outcome that you're really interested in that setting. But I think looking at the general population frailty tool can give more broader idea about where the health issues are that may not be quite directly relevant to the disease or treatment that patient is receiving.
There is another question here. So you enter all the information of the patient, then you get an index, and this index is compared across different tools on the crosswalk. If this is the case, what about the information that are not provided by scenarios entered but are criteria in other tools? Both scenarios do not include information about, I guess, social support, social determinants, which is needed to calculate the TFI, how then one can crosswalk the TFI score that is calculated. I guess that's the question.
Yeah. So there are social frailty index that essentially incorporate social determinants of health and then creating a risk score based on social determinants. And what I considered when we developed the ScDAssociate, we wanted to measure more physiologic and like biologic, measure of frailty separate from social frailty. I'm not saying that social frailty is not important determinants of their care and their outcomes of the treatment, but these are, two separate domains. And then so some of the frailty tools that we put on the crosswalk include social domains, while others don't. So that may explain some of the discrepancies when you see a crosswalk and then, oh, this the crosswalk doesn't match perfectly, which we have seen in our experiences too. But then when you look at what components are included in different frailty tools, maybe that is why the frailty tools do not match completely.
Another question, how does eFrailty website ensure that the various cut points for physical performance measures, such as grip strength and gait speed, are accurately applied in its calculators?
Yeah, so the cut points of physical performance that we include in eFrailty website really follow the original publication of each frailty tool. So each tool may use different cut points to give partial points or points for impairment. So we didn't really, put our interpretation in developing that cut points and then the scores. So we follow the original publication, especially the ScDAssociate that our team developed. The partial points for muscle strength and gait speed, we use the information from some of the previously developed measures, such as frailty phenotype or short physical performance battery, and so on. So we have used some of the previous evidence that have shown that there's increased risk of poor health outcomes with those cut points. But again, it's a continuous measure, so the cut points can be arbitrary, but it's useful for communication purposes with other individuals and professionals.
Maybe we have time for one more. There are many questions coming, but I think some of them go to I guess validation in other countries and whether there will be an app, I guess in a mobile device that you can use that tool at the bedside, maybe at the point of care.
Yeah, you can use your mobile device to access our website. So because it's a web-based calculator, so you can use it on your tablet or computer, laptop, or your phone. We currently do not have plan to develop an app because we when in developing the eFrailty website, we wanted to have the layout when it's accessed through the smartphone and tablet with a different screen size. So, but that's but we have not ruled out completely that possible in the future, but that's not in our near priority for the eFrailty.
Thank you, Dai. I think we run out of time. It was a great presentation, and thank you for answering these questions. And we hope to see you again, all our participants in the next Frailty seminar series. That will be Dr. Sinclair will be talking about diabetes and frailty in October 9th. And we hope to see you there. And thank you again.